Hello, everyone. Thank you for being with us today. My name is Rose Gerber. I'm the Director of Patient Advocacy and Education for the Community Oncology Alliance. For those of you who joined us last month, you may recall that I was very excited to share the big news that COA was on Capitol Hill with a very large group of advocates, over 120 advocates, representing our entire membership. So cancer patients, survivors, oncologists, nurses, pharmacists. It was just a really excellent day, and it was just very energizing and inspiring to know that the day-to-day work that we're doing is making a difference, and to have the privilege of meeting with members of Congress. And today, as you can see from the slide that's right in front of you, we have our Managing Director of Policy, Advocacy, and Communications, Nick Ferreyros. He's going to tell us a little bit more about some of the outcomes of our visit on the Hill. On that day, we had a laser focus. We were focused on pharmacy benefit managers, and we talked about the TACT Act. So Nick is going to, share some updates about that. And then what I want to do, speaking of advocates, just mention a quick reminder to all of you, because this is the first year that we're really, quote, back into normal since COVID happened. CPAN has chapters in cancer centers across the United States. And as great as that Hill Day was, and as happy as we were to have some incredible advocates and survivors with so many stories, we could have had even more of you. So one of the ways to get involved is to visit our CPAN website, which you can access through the COA main website, and sign up to become an advocate. If you don't have a chapter in your cancer center, then you can join our online community. But either way, get involved. And now it's my pleasure to introduce Nick Ferreyros. Nick, we're looking forward to hearing and learning from you today. Thank you.
Thanks, Rose. And, don't forget, I want to keep this a chat. So chime in as I talk. Hey, everybody. Good to be back. I know I was looking at my slides, and the last time I was here was talking about 340B. This is going to be a bit of a flyover. It has been a very busy 6 months at COA and in Washington on our issues and on everything that affects cancer practices, patients, and everyone around them. Don't expect sort of a super deep dive onto these things. We can certainly answer questions as the chat goes on. I'll be paying attention to the Q&A box or the chat box as well. Of course, we can always come back or arrange special advocacy chats on these issues as we go. So, Rose is pretty good about keeping her finger on the pulse of what everyone wants to hear about. So as I mentioned, it has been a very busy 6 months of advocacy for us. This is just a little picture of the 128. I actually think it's probably more like 136. The numbers are, there was so many people. Keeping track has been hard, but we were on the Hill in June in force, the first time since COVID, and it was a really great day. We had 31 states, 200 plus meetings. As Rose mentioned, we were focused on PBMs, and I'll be talking a lot about that. I think, Rose, you would agree it was a pretty productive visit this time around.
Yeah, it was really incredible. And Nick and I coincidentally were in the same group made up of some practices from New England. And again, what was so moving about that day meeting with these offices in Washington is that we had representation from anyone. And again, an incredible shout out to everyone, especially the survivors, but a special shout out to the pharmacists, because they're also really frontline with patients, and the stories that they're telling about a topic you're going to talk about later, Nick, the drug shortages, was really impactful. And then, Nick, I just want to draw I'm really glad that you have this on your side, where you have the 4 committees where they testified before Congress. This large group photo and photos on Capitol Hill, we posted it on LinkedIn, follow us on LinkedIn as well. And we know that we see other advocacy groups that go up to Capitol Hill. We're not the only group, but I think where COA really stands out, Nick, is in that block that you have up on the top left. Like, it's one thing for us to go on the Hill and meet with certain members, but COA leadership, and I'll let you take it from here, is at the highest levels meeting with Congress. And that says a lot about COA's advocacy role on Capitol Hill.
Yeah, you're right, Rose. This is our 20th anniversary, as we've talked about a lot. And 20 years of investment and advocacy has really paid off. And, now we are one of the sought after voices on health policy and cancer policy. So both. And as Rose mentioned, we testified so far 4 times before Congress this year. We actually had the opportunity, I think, to testify 6 times, but have had to turn it down a couple of times because it's not easy, as you can imagine, going and speaking before Congress. But these are, the major committees of jurisdiction that have a lot of oversight over the issues that impact practices, that impact pharmacies, that impact patients. So a very busy 6 months. Also, in addition to all of that, our day-to-day work, comment letters, there's been a couple of RFIs or requests for information from Congress that I'll talk about. And then, of course, 2-3 years ago, we started doing a state engagement work and getting into the state level of advocacy, which I'll talk a little bit about in a minute. So, what is the environment that we're operating in? Those who have seen us talk about policy have seen this slide a little bit, but I feel like it's very important to remember, we have a very divided political system in this country right now. Republicans, Democrats, also the different chambers between the Senate and the House. And that means a lot of negotiating, a lot of working together, a lot of compromise, trying to find solutions and get things to the finish line. And also, frankly, just a lot of letdown, a lot of heartbreak, things that we want to see happen because of the environment we're in are sometimes can become a long shot, even if they are common sense and logical and in the interest of patients. But the good news is, as I'll talk about, some of our top priorities have a very realistic chance of coming to fruition for the first time. And this is an very important year. And then, of course, going into the election year next year, things become very hard to pass. People don't like to look like they're working with each other anymore. It turns off some of the more the stronger base elements, and they don't want to see people working together, unfortunately. So this is a big year for us. I think we all need to remember drug prices, and I say prices in quotes for a reason, because the price of a drug versus the cost that you or anyone as a patient pays at the counter are 2 very different things. That is because of insurers, PBMs, and everyone in the middle changing that. So drug prices, though, are the biggest issue in healthcare. I call it bumper sticker politics. It's very easy to talk about drug prices and pharma and make big bad middlemen out there, make them the big bad boogeyman. But they're still the biggest issue in healthcare, and they're going to remain the biggest issue in healthcare because, as I'm going to talk about, a lot of the things we're looking at aren't shaping up to be that they're going to solve much. We have the IRA coming down the pike, which I'll talk about. PBMs are the big issue in those areas that they're looking for. As I mentioned, a lot of partisanship. And so, of course, the states have a statistically much higher area of passing major legislation. Partially that is because many states have become much more partisan themselves, and so they're controlled in a way. These disagreements can't get through. But also because they can focus more on these issues and focus more on what's really happening sort of at that ground level. So states are really a big place of action for a lot of the issues that we at COA are facing. In one slide, what are the big things on our radar right now? Cancer drug shortages, a huge crisis that's ongoing, hasn't been fixed, has really been going on for decades now. When I'll talk about Ted testified on cancer drug shortages 12 years ago, and he still testified on it this year. So we haven't fixed that. The Inflation Reduction Act, and it includes a lot of provisions around drug pricing and negotiation. Stark Law, which is this wonky little thing, but has really impacted how practices and pharmacies can get patients their drugs, and new restrictions on that. A growing focus on hospitals, 340B hospitals, nonprofit hospitals, charity care in hospitals. Hospitals, are now squarely in the light. And then, the big topic, this could almost be an entire presentation on PBMs, but it is pharmacy benefit managers and PBMs. That is that is where we're seeing a ton of action in Congress now that they've gotten their pound of flesh on the Inflation Reduction Act last year. The enhancing oncology model, I'm just going to do a quick little bit on that towards the end here, but, wanted to talk a little bit about what that is, because that makes a big difference. The way we reform cancer care, make it better, focus on efforts to do that, but also how the federal government is approaching it and whether that's going to succeed or not. And then, of course, state policy engagement. So as I said, there's a lot here. I still have 30 more slides to go. So it's going to be a quick flyover, but we'll come back to some of these as you want. Cancer drug shortages, huge crisis. Any patients in active treatment right now, whether they know it or not, have been impacted and had these conversations happen in the practices that they're going to. Particularly the platinum drugs, carboplatin, cisplatin, are huge and ongoing crises and shortages. We've seen this going on for months now. It's causing care to be delayed or canceled. It's causing treatment plans to be changed. We've worked a lot to raise awareness around this, get Congress to work on solutions. We've testified. Actually, on the day of our Hill Day, Ted was testifying on the drug shortages. And as I said, he did this 12 years ago. So big deal. And, nobody likes to talk about paying drug companies more. It is not something that, that is a winning argument in Washington, but that is the fact of the matter. Whether we want to talk about it or not, there are different worlds of different kinds of drugs, just like there are different kinds of cars. You have Hondas, you have Ferraris, you have generic drugs, and you have brand name drugs. The brand name drugs are the ones that make the big headlines. So, the $100,000, the $1 million drug for this and that are new drugs coming out. But generic drugs are an increasingly big part of our drug system. And what we're seeing shortages in right now are what are known as sterile generic injectables. So these are drugs that are injected into patients. They're sterile, meaning they have to make sure that they're made in a very controlled environment, and they're generic. So they're no longer those big sticker priced drugs out there. And what's happened over the years is the price of those drugs has gone down and down and down and down. That's for a lot of reasons. One is they've gone generic, so they're inherently going to be a cheaper drug anyway. But our drug supply system, and this includes a lot of the things I'll talk about later, PBMs, 340B, our drug supply system then adds in all these discounts that manufacturers, that pharmaceutical companies have to apply to their drug prices. So taking the price and the net price down even more and more. So what the drug company is putting in their pocket at the end of the day is extremely low on these generic injectables. So low, in fact, that they're not able to, they don't want to manufacture them anymore. They're not making any money on these. Sometimes they're losing money. They're certainly not investing in their factories and the capacity to do it. And so what that means is that you have 1, 2, 3 people making the majority of these cancer drugs that are, again, generic injectables. And any little issue in the supply chain, any little problem in the supply chain causes there to be a big shortage. Additionally, you have companies pulling out. They say simply, we can't continue to make these drugs. We're not going to continue to make the drugs. It's not worth our time. It's not worth our energy. So we have to fix this. We have to solve this problem. We can't force them to make it. That's not the kind of world in which we don't force people to do labor for us. So how are we going to fix that supply and demand imbalance of financial and economic incentives to get a drug company to make the drugs? There's no shortage of the $100,000, $1 million drug. There is a shortage of the $10 drug. The cisplatin and carboplatin are $10, $25 drugs. They're very low cost and we have to solve that problem. We testified about this. We've submitted a very lengthy, what Congress called a request for information. And we're continuing to get focused media attention on it. I know a lot of our advocates and practices have been featured in pieces on this issue.
And Nick, and also this is a fantastic slide, and I think your analogy using cars is so on point. It's a fantastic analogy. I believe that we have the RFI on COA's website. Is that correct?
Correct. Yeah, that was submitted on Monday this week. No, Friday of last week, actually.
So again, as Nick mentioned earlier, we give you all the highlights, but if you want to learn more, feel free to please go and read that. And talking about keeping the conversation going, we're talking about patients and how we can always elevate our voices. Well, one of the most impactful publications is New York Times, and there was a feature story on this issue, and there was a vocal cancer patient from a cancer center in Fresno, California, the patient of Dr. Ravi Rao. And if you can find that on our website, and it's very moving. And for any cancer patient or caregiver out there, when you read the stories, he was one patient featured, but there's other patients featured in the New York Times article. And it just talks about how he's going in, and when he meets with Dr. Rao, at first he's very optimistic, even though this vocal cancer is very rare, that with the prescribed treatment that Dr. Rao wants to give him, there's an 80% chance of health in the future. But then because of, he has to, as an oncologist, keep that dialogue open. He has to let his patient know that, these drug shortages are real. And of course, you can imagine the despair that a patient would feel. Any of us that have been patients, you want to know that at least you're going to get better and you're going to have the medication that you need. And I believe he uses the term, it feels like Russian roulette. And so far he is getting the medication, but these are real life issues and impacting real patients. And again, Nick, this is a fantastic slide. Thank you. Thanks,
Rose. Yeah, it's a big problem. And there is, unfortunately, no meaningful solution that I have seen in Congress to this problem. Democrats don't want to talk about paying drug companies more. Again, even though I've pointed out Honda versus Ferrari, generic versus brand, Democrats don't want to pay drug companies more. And so we're at a bit of an impasse right now. The Inflation Reduction Act, the IRA, which was a major marquee piece of legislation passed in the Congress a couple of years ago, has several provisions in it on drug prices and addressing drug pricing. Certainly several good ones, capping out-of-pocket costs, the catastrophic phase in Medicare, but one of the biggest ones that we're focused on right now is that the IRA gives Medicare the power for the very first time ever to negotiate drug prices we have one question: where's the RFI on the website? You can go on the website under publications. Also, you can go under our press releases. The last press release we put out on Monday, we'll have a link to that RFI as well. But going back to the IRA, a lot of drug pricing provisions in there. We are focused on what's coming down the pike in 2028, and that is the negotiations. Negotiations on paper, great idea, great in theory, right? Who doesn't want to see someone negotiate the high price of drugs? And there's certainly a lot of validity to that. The problem is the way in which negotiations are being structured. They place the providers, meaning your cancer doctors, in the middle of the negotiations. Ted likes to call it holding them hostage. It's not a term, it's a very aggressive term that I don't like to use, but it does make sense. And essentially what happens is it's going to result in these negotiating the prices, feeding those prices back into what our doctors are paid, will result in them really making about 47% less on what are called add-on payments. Now, you might say, oh, the doctors are losing money, woe is me. Yes, but this is money that over the years, CMS, the Medicare agency, has cut payments for cancer care over and over and over again. Practices have had to go through record inflation. These add-on payments aren't just profit. These are payments that are used to run the pharmacy, mix the drugs, dispose of the drugs that are often toxic chemotherapy agents. They frankly keep the lights on in the practices. And it's going to be a big cut. The way in which the negotiation provision is implemented has a big impact on our practices. Of course, there's all the other things that we worry about too. The IRA doesn't touch any of the other issues in our healthcare system like 340B or PBMs, and only impacts Medicare. Then there's the long-term concern about investment in new drugs. Cancer care, of course, we care about these sort of groundbreaking, life-changing new drugs that come out because, frankly, they transform cancer care, and we're practicing space-age medicine because of the investment in new drug development. So there has to be a balance there somewhere. But also, we need to also make sure, I talk about the unintended consequences of bad public policy all the time. And this is one of those that can have serious unintended consequences on independent practices and push them out of business, frankly, and into the hospitals who benefit from things like 340B, but also mark up drug prices 5 times, send patients to debt collectors, and are nonprofit, so they're not contributing to your local schools or tax bases. Where are we going with the IRA? Lots happening right now. Just because this bill was passed 2 years ago and is the law of land doesn't actually mean this is happening. A lot happening in Congress, in the government right now about stepping up and preparing for this. There's a lot of headlines out there about maneuvering between pharma and the government about it. Politics. The Republicans are dragging this out. The Democrats are celebrating it. 24 elections are going to have a big impact on how this happens because, again, it doesn't really kick in 2028 on this side of things. But the most likely place is that this is going to be decided by the courts. There are at least 4 lawsuits out there right now. And they all talk about a lot of different things. I think there's probably going to be more lawsuits. And so this will probably end up at the Supreme Court arguing over constitutional issues around this. I talked about Stark Law. Let me just check this question. Okay, that's one done. All right, so I talked a little bit about Stark Law and how practices can deliver drugs. During the pandemic, the government gave practices leeway to deliver patients their drugs, meaning these are oral pills. And so suddenly we saw what the system was possible of, as giving patients their oral medications either by delivery or courier. And then now that the pandemic ended on May 1st, CMS said, you can't do that anymore because it's a violation of what's called Stark Law. Stark Law is a wonky part of the government interpretation of antitrust, where doctors are doing self-referral. So somehow they're giving themselves more business by doing this. We don't understand how that works. The doctor, regardless of how the patient gets the pill, the doctor writes a prescription and the patient picks up the pill at the pharmacy. Just because the pharmacy is helping the patient get that pill, sending it to them by courier or delivery. Even, by the way, a strict interpretation of this new change is that family and friends can't pick up the medication for you. So the patient themselves has to. That is we don't understand how this is a violation. It doesn't really make any sense. And so it's a big deal. Congress has been listening to us on this as one of the topics during our Hill Day. And CMS, their response to all of our problems is they can just get it from their PBMs. Now, as I'll talk about, as anyone who's ever dealt with a PBM mail order knows, PBM mail order is not always the easiest to deal with. Endless problems, endless delays for patients, delays, denials, lost medications. It's currently the summer. Outside my window, it's 91 degrees. If I had medication delivered and I wasn't working from home, that's sitting, outside in the sun. Also, these medications are expensive. They're often stolen. I mean, anyone who's ever had an Amazon package stolen from their front porch knows about that. So there's a whole world of problems here, but the long story is, yet again, the unintended consequence of misguided public policy coming to play here, and it's impacting patients in a very real way. We're seeing patients having to travel hundreds of miles for their medication. One patient I know today is driving around 900 miles in Texas to get his drugs from his practice. So big problem. We are preparing at COA to sue over this issue. Preparing a lawsuit takes some time, but we're doing that. Rose, I am killing time here, so I'm going to run very quickly.
Can I just pause you for a second?
Sure.
Because I know, we try very hard to stick to our timeline, and we normally do, but people are always free to exit. But if you could go back one slide, because I think it's so important. The hardship on patients. So one of COA's initiatives is health equity. And what we know is happening nationally, not just to patients treated in community oncology practices, but people are really struggling financially right now. People literally are struggling to buy groceries and to have money for gas. So there's so many ramifications about these issues, and I'm glad that we're covering them. Thank you.
No problem. I'm going to skip through our 340B slides, but, at the end of the day, you can go back and watch our 340B session. The problem here, of course, is that hospitals profit tremendously from the program, which is meant for them to then expand their charity care and access to care. They use those profits to force independent providers out of business, consolidate the healthcare system, and raise their prices. On the advocacy side of things, we are seeing an incredible amount of focus on these issues. Hospitals are in the spotlight like never before. There's a lot of scrutiny over their charity status, their nonprofit status. There's a lot of scrutiny over where these 340B dollars are going. I'm not confident that we're going to see a lot of action here on 340B this year, primarily because every congressman knows the CEO of their local hospital. The hospitals are many times the biggest employer in local markets. They are, frankly, they're sometimes too big to fail. This is a program that has grown and grown and grown, tens of billions of dollars. I think $56 billion is one of the numbers I had on one of my earlier slides, in just pure profits for hospitals in this country. But if you want to learn more about 340B, there is no shortage of that resources on our Advocacy Chat archive. PBMs, this is where we are focused strongly, where our Hill Day was completely focused. It's where the most likely area for action in Congress right now. There's a ton of bills happen in Congress right now. I think last I checked, at least 17, 18. There was a new one introduced yesterday. There's more coming down the pike. It's never going to stop. And it is now a bipartisan issue. Pre-COVID, you were not seeing Congress talk about PBMs the way they're talking about it now, at least not both sides of the aisle. We'd go in, even last year, we'd go in, talk to Congress about a PBM. Some offices would be like, what's a PBM? Can you take a step back and explain it to me? Rose was there with me during our Hill Day. No office said, what is a PBM? In fact, many offices said, oh yeah, you're the second meeting I've had today on PBMs.
Right, Nick, and just again, because I love to share, old school copies where it's out of set now, we actually left a lead behind that had all the PBM bills. So this is a huge, huge issue.
Yeah.
It's to be resolved.
Yeah, big bipartisan movement on this. We at COA alone, out of those, we've testified 4 times this year. We've testified 3 times on PBMs this year. So definitely a very, very important thing. This is just a small list of the bills. It's actually probably not even close to updated. As I said, at least 17 pieces. What this means, the more discussion, the more solutions that are on the table in Congress, the more likely it is that they're able to narrow that down and come to at least 1 or 2 or a handful of solutions. So it's not one of these issues where it's really contentious and nobody really knows what to say. There are a ton of solutions on the table right now. There are more coming also. So PBM action this year, hopefully meaningful PBM action, really strong, is coming. Pressure is building, as I said. So the enhancing oncology model, I just wanted to flag that once. The enhancing oncology model is the government's effort to improve and transform the way cancer care is delivered. It's one in a many range of what are called reform models from the Center for Medicare and Medicaid Innovation, where they are attempting to fuel transformation in the industry. The EOM is the follow-on to its predecessor of the oncology care model that a lot of practices participated in. Unfortunately, the EOM has a lot of flaws that practices do not like. These models are very expensive to participate in. They require a lot of staff time and resource and investment. The EOM also includes what's known as downside risk, meaning that a practice could lose money and significant amount of money on it. We have been talking with practices, as my next slide will talk about, we are completely committed to reform. We want to see the system get better. We want to see things change. We want to be leaders in this. Community oncology actually has been one of the leaders in oncology care transformation, leading the oncology medical home, helping define what is high quality cancer care. You've seen an advocacy chat in the past on the oncology medical home. There is a lot of room for us to make this better and to improve the patient experience. Unfortunately, the EOM, as practices talked about, is not necessarily it. There's a lot of room for improvement. We did a survey early on that showed that practices have talked, and only 67 joined the EOM. Of course, that is a preliminary number. It's almost certainly not the final number. We know that at least 2 or 3 from that list are not actually participating, whereas its predecessor had double that, 122 practices. So the message here is, the federal government wants to lead transformation efforts, and we want to participate in them. But there is a question over whether they're going to be able to do that appropriately and meet the needs of practices and take feedback and work. I often think of the federal government and Medicare as the Titanic, and not so much in the horrible story of the Titanic, but you can't steer the Titanic on a dime. You can't just change things. And when we've been talking with CMMI and CMS about this program and about these efforts for years. I mean, since they ever started, and they listen to our feedback. They want to hear our feedback, but whether that actually translated into change is different. So who knows what's going to happen? But this is also a place where the government goes to its toy box of resources and tools to drive other change, whether it's on drug pricing. So definitely pay attention to what's happening in CMMI. I mentioned states. We have a very strong state policy team that helps practices track and engage in what's happening at the states. A lot of states doing bills that affect our issues this year, 350 plus of them. I mentioned the passage rate at the state level is much higher. A federal bill has about a 3 to 4% chance of passage. A state level bill has a 20-ish% chance of passing. That is a huge difference. And so, if you want to say, where should I invest my time in transforming the system, making it better, improving the things we're facing, it's at the state level. And really, what's helping push PBM issues is that middle bar you see right here, PBM licensure, PBM transparency, because these are all the issues that you're seeing in states that we're tracking right now. But states are taking the lead on PBMs. Congress has noticed that, and Congress says, well, we can't be left behind. We can't let our states do that alone. So PBMs are on the state radar as well. PBMs are really where we are focusing a lot of energy at the state level in doing everything from helping sort of just cast a light on what's happening there to really sort of nipping in the bud all of their bad behaviors that hurt patients, prior authorization, waiting for approval for your treatment plan, dealing with white and brown bagging. These are where the drugs don't come from your doctor, but have to come from a PBM pharmacy. So that can cause delays and problems in your treatment, and then all sorts of coverage issues. So states are really where a lot of the action is. Going back to this slide, just to sum it back up, again, drug shortages, big crisis right now, and it's not anywhere close to being fixed. And people have their head in the sand right now. And all estimates are that these drug shortages are going to continue through at least the end of the year, if not into next year. And as I said, we've been dealing with this for over a decade. We're going to keep dealing with this until we really solve this problem. Other things like the IRA, 340B, PBMs don't help it. We are focused on the IRA and helping ensure that the public policy of negotiations and drug prices is implemented appropriately and doesn't hurt patients or practices. Fixing that Stark Law, mail order or drug delivery issues, helping shine a light on 340B abuses and hospital consolidation because of the impact on patients, raising costs. PBMs. I could do this entire presentation again on just PBMs, helping chart the future of cancer care with the EOM, and then getting engaged in state level policy. And Rose, I have flown through these, but hopefully people got something out of it. Feel free to, if you're still around, I know we're 5 minutes over, but we'll take questions, we'll take chats, and if not, we'll definitely have more presentations on these issues.
Nick, can you just go back a couple of slides, the graph that you had, I just want to draw attention to that one. Just to everyone in the audience, when you look at the descriptions, I mean, all of this is definitely, for some of you that are new to the policy world, what we'd call wonky verbiage, but every single one of these issues has a patient impact, every single one. And I think it's important. And again, we provide so many resources for our advocates to learn about it. So thank you, Nick.
Yeah, these are, these things you see on this, when it comes to real life, when it comes to really getting your treatment, these are sort of the worst of the worst, as it were. We are, this is just a handful of them. We actually have, I think, like 35 plus issues that we're tracking. We have an interactive map on our website. We update that every week. There's a lot going on, and this is not just in the States. I mean, there are federal issues around this that we work to tackle, but this is where the rubber meets the road on, like, when you walk into your doctor's office and being able to get the treatment, how you get that treatment, and how much you pay for that treatment is all dealing with this, sludge, this crap. I'm sorry, pardon my French, but it's crap. I mean, the stuff that we put patients through, when you hear you have cancer, you should not have to deal with spread pricing, and the steerage and home infusion issues that you may not want. So these are big issues that we're focused on.
And, Nick, too, it could be a topic for another time, and we've covered it before, but even biosimilars, you're talking a lot about the cost, and even your knowledge about vehicles, there are more affordable options. Biosimilars is one of them, but there's not a big adoption because, again, it's less beneficial to use the biosimilars. So again, so much great information. And Nick, why don't we go ahead and jump ahead to a slide that I think everybody's going to love. So again, thank you, Nick. I think this was a fantastic presentation. Your analogies were perfect. And we're all going to try to remind ourselves to have some fun. So we're going to be taking an advocacy chat break for August, but we'll see you back in September. And we won't tell you what the topic is just yet, but we're already working on it. And it's something new, and we know that you're going to like it and learn from it. So thank you again, Nick, and thank you to our audience. Enjoy the rest of your day.
Thank you, Rose. Thanks, everyone.